Okay, let's get started. Let me welcome you to, I don't know, maybe the 10th seminar this semester. This is our departmental seminar series. And today we have Dr. Ramsey, who is the Director of Medical Physics at the Thompson Cancer Survival Center. He received his BS, MS, and Ph.D. in nuclear engineering from the University of Tennessee. His MS research was in the area of space radiation protection, and his Ph.D. research is in the area of medical physics. And we're indeed pleased to have him with us today. The subject of his presentation is state-of-the-art radiation therapy. Okay?
Thank you. First of all, for those of you who are not familiar with the Thompson Cancer Survival Center, we have two different facilities here in Knoxville, one downtown behind Old Charlie's and one out west next to Park West Hospital. In radiation therapy, we use high-energy linear accelerators to produce X-rays to treat patients with cancer. And this is a photograph of one of our linear accelerators. The radiation is produced in the head of the linear accelerator and is directed toward the patient through these leaves called multi-leaf collimators. They're 1 centimeter wide, 10 centimeter thick leaves of tungsten, each individually controlled by motors and computer circuitry to move back and forth, either while the radiation beam is on or while it is off. In radiation therapy, we use CT scanners to generate three-dimensional models of the patients. And we use the information from the CT scans to develop three-dimensional treatment plans and transfer this information from the computer to the linear accelerator, which is under computer control and directs cross-firing beams of radiation at the cancerous tissue while missing healthy tissue. One of the most significant advances in recent history in radiation therapy is a technique called intensity modulation. Intensity modulation is a technique where the radiation beam is dynamically shaped to conform to the shape of the cancer tissue. In this example, I've got a linear accelerator rotating around what's supposed to be a block of granite, because this is also called dose sculpting. As the linear accelerator is rotating around, the radiation beam is shaped from all directions, and the summation of all these cross-firing beams allows us to create virtually any shape in radiation dose. We're able to accomplish this through using these multi-leaf collimators. Here we've got the MLC leaves, and they're sliding back and forth while the radiation beam is on. This allows this beam of radiation to pass through the target, in this case, a prostate, selectively hitting the target while missing surrounding critical structures. How are we able to do this with the multi-leaf collimator? Here I've got a shape that we would like to make in radiation dose. Down here at the bottom I have the multi-leaf collimator leaves. And we've got a window between these two leaves. And it starts on one side of the field. The radiation beam turns on and deposits this red amount of dose. And then the leaves move on to the next position and deposit radiation dose in this next segment. And this is repeated by sliding this window from one side of the field to the other to make any three-dimensional dose shape. There are several different techniques for doing intensity modulation. The first is the step and shoot technique. In step and shoot intensity modulation, the multi-leaf collimators are only in motion when the radiation beam is turned off. So it's a summation of different segments of radiation. The beam turns off, the leaves move to the next segment, the beam turns on for a certain amount of time. And it's almost like stacking up Legos. And you can build a three-dimensional dose shape. This particular technique is especially useful in head and neck cases. Here I've got a computer reconstructed radiograph of a head from the right. And here in these different shades of color, I've got different levels of dose intensity. The dose intensity that I have shown now would be without any intensity modulation. This is straight two beams coming from the right and left lateral. There's a spread in the levels of the dose here between 80% in the blue and 105% in the pink. We don't want that. We want the radiation dose to be completely uniform across the field. And we can do this with step and shoot intensity modulation by exposing this initial field until this 105 portion, which means it's getting 105% of the prescribed dose, gets to 100% of the dose. Then the MLC leaves slide over and block that portion of the field. The rest of the field is now underdosed. It hasn't got enough dose yet, so the beam turns back on sequentially until each of these fields reach the prescribed dose. And what we're able to do is take this dose distribution, which is very heterogeneous, and make it a very homogeneous dose distribution. And what this has the effect of doing is improves tumor coverage up here in the superior portion of the field and significantly spares the larynx, where we have a dosimetric hotspot. Another type of intensity modulation is the sliding window technique. In this technique, the MLC is in motion while the beam is on, and the intensity is varied by changing the gap width between the two leaf banks. The only time that the beam turns off is if the motors driving the multi-leaf collimator leaves are not able to keep up with the planned position, then the beam will hold off until these leaves catch up to the correct position and then turn back on. But that's all automatic under computer control. This is a patient that we recently treated who has a very large tumor wrapped around the spinal cord. This is called a paraspinal mass, and these cancers are very difficult to treat because the spinal cord can only tolerate about 45 gray, but it takes about 60 gray to kill the tumor. So the real challenge here, since this tumor is wrapping around the spinal cord, is how do you treat it without paralyzing the patient? Fortunately for us, this particular patient had a vertebral body removed right in here and had these steel rods in place implanted in his neck to keep his neck very rigidly immobilized. I say fortunate because the real difficulty with these cases is you've only got about 1 millimeter or 2 space between the tumor and the spinal cord, and the patient has to be in exactly the same position. And because of these rods, we were able to reproduce his setup very accurately. Just to go through the process of how we go about coming up with one of these intensity modulation plans, we take a 3D model of the patient and place, in this case, 4 converging beams posterior to the patient, converging on this mass around the spinal cord. This is the resulting dose distributions that we were able to achieve for this patient from those 4 beams. Just to describe what all this is a transverse CT cross-section with the radiation doses, the calculated radiation doses superimposed over top of it. The purple color here is the volume that is receiving 60 gray, the red 55 gray, the green 50 gray, and the blue 45 gray. The spinal cord is located right here in the center, and we've got lungs on either side. And you can see as we go through the CT slices, the dose distribution wraps very nicely around the spinal cord. This was not treatable at all with radiation without intensity modulation techniques. In fact, this patient first went to University of Kentucky, Duke, and then Vanderbilt. None of those places offer this type of treatment, and they all turned him away from treatment, and he eventually found his way to us. And he came here for his entire course of treatment from Lexington, Kentucky, where he lives. When he started treatment, he was told that because of the rate of growth of the tumor, that he would have about a month or to a month and a half before he would be paralyzed from the neck down. And when he completed treatment 2 weeks ago, he had regained almost all of his motor skills that had been inhibited by the growth of the tumor. This is a 3D rendering of the spinal cord and the 50 gray isodose cloud. You can see quite nicely how the cord goes right through the middle of the dose distribution. This plot is called a dose volume histogram. What we have on the x-axis is the dose that is delivered, and on the vertical axis we have the normalized volume that is receiving that dose. In red we have the tumor, and in blue we have the spinal cord. Coming up from this 40 gray line, you can see that 100% of the tumor is receiving at least 40 gray, but basically none of the spinal cord is receiving over 40 gray. Remember, that threshold for spinal cord injury is at 45, so we wanted to leave some space here in case of setup error. The tumor, approximately 87% of it is receiving 50 gray, and 50% of the tumor volume is receiving 60 gray, which explains why this patient responded so well. The next type of intensity modulation delivery is dynamic arcing. The next two techniques now involve the linear accelerator rotating around the patient and modulating the beam. In conformal dynamic arcing, you have a target volume that is in the patient. Let's say a prostate, for example. And during conformal dynamic arcing, the radiation beam turns on, and the gantry rotates around the patient with the MLC leaves continually conforming to the shape of the target, which is this red block, from each gantry angle. This particular technique can be useful in spherical or regular-shaped objects. In this particular case, we had a patient with a rather large mass attached to the pelvis that is sandwiched in between the large intestines. We wanted to treat this lesion without damaging the intestines, and we did this with a 360-degree arc around the patient with the MLC leaves conforming to the shape of this target from each gantry angle. Another example of a situation where this is very useful is in intracranial lesions. In this particular case, I've got two target volumes located inside the brain, and for both of these, for each lesion, each of these two lesions, the linear accelerator does a 360-degree rotation around the patient with those MLC leaves conforming to these shapes. And in this particular type of arrangement, we're able to give in upwards of 80 gray to these little lesions without exceeding 40 gray in the surrounding healthy brain tissue. Of all the techniques for intensity modulation that I've talked about so far, intensity modulated arcing is by far the most complicated, but it will give you the best dose distributions. In intensity modulated arcing, like conformal arcing, the radiation beam is on and the linear accelerator is rotating. But instead of conforming to the shape of the target, the leaves modulate the intensity during gantry rotation, similar to that sliding window technique that I talked about earlier. And this delivery can be done in either a single pass arc or multiple pass arcs going back and forth over the same area to build up a specific, very complex dose distribution. In the computer animation that I showed at the beginning, where it was sculpting in the granite, it was this type of technique that was being used. We're currently using this technique for prostate treatments at the Thompson Center. This is another dose distribution, but this is the old way of treating the prostate. This is what's called a four-filled box. We've got four fields, which are represented by these yellow lines converging in the center. And you end up with a dose distribution shaped like a box, hence the name. In the 90s, the new standard became a six-filled approach, which gives us this nice football-appearing dose shape. And this is achieved with 6 beams converging on the prostate. Both of these treatments, however, deliver a significant amount of dose to structures that don't need that dose. In the four-filled box arrangement, you've got over half the rectum receiving the entire prescribed dose. And this really limits the amount of dose that you can give to the prostate because you don't want to exceed normal tissue tolerances. In the six-filled approach, you decrease the radiation dose to the prostate, but in this area here, you have the nerves that control the incidence of impotence running through here, and you're giving radiation to that, which increases the probability of impotence, which is very bad. With intensity modulation, we're able to define the prostate, the rectum, and very clearly define a boundary between the two of them. The particular approach that we use is the intensity modulated arcing, where we use 2 arcs from either side. And this is a series of images looking, if you were sitting where the radiation source is, looking through to the patient. The red portion is the prostate, and the orange portion is the seminal vesicles. You can see during gantry rotation, the MLC leaves are differentially blocking here the rectum, and then in other fields exposing the entire prostate and seminal vesicles. The net result, I've got a comparison here for the six-field technique and then for the intensity modulated arcing technique to blow it up bigger so you can see it. Just to reiterate what I mentioned earlier, we've got certain margins around this prostate that we want to keep, but we want the dose distribution to slide inward. And this is what we were able to achieve with the intensity modulated arcing. These dosimetric margins, which we wanted to keep in those two directions, are the same, but we were able to push laterally the dose distribution in and spare a significant portion of the rectum. Back to another DVH. This is the dose volume histogram for a six-filled rectum, and then here I've got the intensity modulated arc treatment. At lower doses, the modulated arc technique actually gives more dose to the rectum, but that doesn't matter so much because the rectum is a threshold response, which occurs at about 6,000 centigrade, which is where the switchover comes between the two plans. Both of these treatments give a 3% probability of a rectal complication, where this rectal complication is more than 3 episodes of diarrhea in a day beyond pre-existing diarrhea. However, the difference comes in the amount of dose that we're able to give to the prostate. With the six-filled technique, we're only able to give about 74 gray to the prostate and keep that 3% complication. With the intensity modulated arc technique, we're able to give upwards of 85 to 90 gray to the prostate and still maintain that 3% rectal complication. So what does this mean? Keeping the rectal complications the same at 3%, if that's your set-off limit, give as much dose as you can to keep that rectal complication probability at 3%. Your tumor control probability for PSA 10 to 20 is only 61% with the 3D conformal technique, and it's 95% with the intensity modulated technique because we're able to get more radiation dose in there. Normalized to comparing the two with the same tumor control probability, 95%, would give you a 16% incidence of grade 2 rectal complications. Another particular patient that we treated was a relatively young man, 45 years old, with metastatic prostate cancer to the pelvis. Metastatic prostate cancer, unlike other metastatic disease, grows very slowly. So even though this patient had metastatic disease, his lifespan will be on the order of 10 years remaining. And this particular patient was in extreme pain because of this metastatic disease. And what we were faced with was, are we going to be able to help this patient have a high quality of life for the next 10 years, or is he going to be on morphine for the next 10 years? What in this particular plan, what the physicians wanted was less than 95% of the prescribed dose to the femoral head and less than 20% of the prescribed dose to everything inside the pelvis. And this is the 3D dose distribution that we were able to treat this patient with. And you can see that there is a nice hole here in the dose cloud where the femoral head would go in. This next patient is perhaps the patient that we're probably the most famous for, which is a mesothelioma. In mesothelioma patients, you have cancer that surrounds the lung, and it originates from asbestos exposure, and it doesn't infiltrate the lung itself. It grows in between the lung and the chest wall and expands. As it expands, it causes the lung to collapse. Well, the lung is a very radiosensitive organ. It can only handle about 20 gray, whereas this particular type of cancer would require upwards of 60 gray to control it. So conventionally, radiation therapy wouldn't work. As you can imagine, surgery can't be tolerated by most of these patients because it pretty much involves removing the entire lung. And this particular cancer doesn't respond at all to chemotherapy. However, with intensity modulation, we were able to deliver a 360-degree intensity modulated arc where each beam was tangent to the surface of the lung as the gantry rotated around, which was able to give us this dose distribution with less than 20 gray to the healthy lung tissue and greater than 60 gray to the disease. And this is a movie loop of the MLC lead moving as the linear accelerator is rotating around to give you an idea of what type of shapes are involved to deliver these dose distributions. After intensity modulation, the next big advance in radiation therapy is respiratory gating. As for patients with tumors in the lung, as the patient breathes, the tumors move up and down. Typically in radiation therapy, the field size is increased to encompass the motion of this tumor during respiration. However, this leads to the irradiation of large volumes of normal lung tissue, which I mentioned earlier, very radiosensitive. What we would like to do is selectively target one portion of this respiration cycle. And we do this with a CCD video camera with an infrared illuminator ring, and by placing a marker block with reflective markers on the patient. Now this marker block is placed on the patient's chest, and as the patient breathes, this block moves up and down. Infrared light from the illuminator ring floods the room and is reflected back from the marker block to the CCD camera, which sees the two reflective markers. And the computer system tracks the respiration by watching the vertical motion of these two blocks. And this is a video from the camera's eye view of the marker blocks moving during respiration. When the respiratory gating is accomplished by selecting a threshold, and when the marker block falls between those thresholds, the beam turns on. And when it is outside the threshold, the beam holds off. This technique is also applied during the CT scanning of the patient. The top image here is of a patient who had a CT scan without the respiratory gating system involved or enabled. And you can see various motion artifacts from the respiration. And the bottom image is gated CT images. And you want to take these gated CT images so that you can develop a 3D intensity modulated treatment plan to treat these patients. So the images have to be acquired in the same phase of the respiration cycle as you're going to treat in. This is a series of images taken during treatment of a patient that was undergoing respiratory gated treatment. And I have here in gray the tumor volume, and this is a view from the front to the back, anterior film. And during respiration, the tumor is moving some, but the original motion, we were able to reduce it from 2 centimeters of motion during respiration to 6 millimeters of motion, which allowed us to shrink this field size by about a third, which resulted in a 20% decrease in lung complication rates. The next step in state-of-the-art radiation therapy is using PET imaging in radiation treatment planning. The latest generation PET scanners, and this is not a picture. This is a regular PET scanner. I couldn't get any pictures of the new hybrid PET scanners. Hybrid PET scanners are the latest and greatest. It's a PET scanner combined with a CT scanner in the same gantry to take simultaneous CT and PET images. Why are we interested in PET imaging? This is an MRI image of the brain. There's a tumor in there somewhere. With MRI and CT imaging, it's very difficult to in some cases to see where the cancer is. With MRI and CT, you see anatomical information. However, with PET imaging, you're seeing biological information. You're seeing metabolism. And this allows you to see very well where the cancerous tissue is growing. And by taking these images and fusing them together, you can very clearly delineate in the anatomy where the cancer is and then direct your radiation beams at it. Here I've got an example of a lung cancer patient, and I've got the PET-defined target volume and a CT-defined target volume, which are 2 different sizes. What we would do in this particular case is we would treat the larger CT-based target volume, which probably includes some necrotic tissue, to a lower dose than we would the PET-based GTV. We would give it probably about 25% more radiation dose than the CT-based GTV. The culmination of all of this technology, let's roll all this together. Let's come up with a way to do respiratory-gated, intensity-modulated treatments for lung cancer using functional imaging. Right now, this is about as state-of-the-art as you can get in radiation therapy. And this is a patient that's under treatment currently. This is a view from the front of this particular patient. We start off with a anterior field and then intensity modulate it. Rotate the gantry around to the back side, intensity modulate the same field, and then start a 360-degree intensity modulated arc to encompass both the mediastinal lymph nodes lit up by PET imaging and the target volume itself. And buried inside of here, this is the 60 gray isodose cloud. We're able to very conformably shape to the tumor. Buried inside of this mass is the tumor itself. This is sitting over top of the heart, where lymph nodes are involved, and then you can see it kind of curves around. The heart comes up from underneath this structure. This area in blue now is the volume that's receiving 45 gray, and then buried inside are the two lymph nodes that were lit up by PET imaging that are receiving 50 to 60 gray of radiation dose. Going to transverse CT cross sections with the radiation dose superimposed. The primary tumor lesion is located over here next to the chest wall. This is heart tissue here, and we've got the mediastinum, where it's usually suspect for involvement, is being irradiated to a different level than the heart, in this case 50 gray as opposed to 40 gray. As I page through, you can see that a great deal of the lung tissue is being spared, which is different than conventional techniques. Here I've got another dose volume histogram, and in red I've got the target volume, in blue the lymph nodes, in green the left lung, and in light green the right lung. Now, using this technique, this is what it all boils down to, is with conventional treatment techniques for the lung without the cancer in it, the healthy lung, there's a 5% probability of developing radiation pneumonitis in that lung. And what that is a very painful inflammation of the lung. That tissue is pretty much no longer functioning tissue, and it's generally all around unpleasant. But in conventional techniques, we have a 5% probability of that. In the healthy lung, that's unacceptable. With conventional techniques in the treated lung, there's usually a 20% incidence of radiation pneumonitis. Using these intensity modulated arcing respiratory gating techniques, we're able to reduce that probability down to 0% in the healthy lung and 1 to 3% in the treated lung. And the other thing that we're able to do is with lung perfusion. The lung tissue is a no threshold. It starts receiving radiation damage at 1 centigrade. With doing the ARC technique around it, we're irradiating more healthy lungs than we normally would with 1 or 2 directions of beams focused on the tumor. But even with this spreading out of the dose from multiple different angles, we're still able to keep the same amount of lung perfusion decrease. And what lung perfusion it's a subclinical effect. You can't tell a difference, or the patient can't tell a difference, but it's equivalent to damage that would be done during smoking. Is a good comparison. Other tissues in one of the really dose-limiting structures in lung treatments is the esophagus. Typically, the complication rate is about 30% with conventional techniques. We're able to drop that down to 6% with this technique. With the heart and spinal cord, 5% complication rate. In conventional treatment techniques, we're able to drop it down to 0%. But the bottom line is we're able to give more tumor dose to the target and the involved lymph nodes. In conventional treatment, 60 to 70 gray is all you could give. Now we're able to give 70 to 80 gray. Well, this means an increase in 2-year survival for these advanced lung cancer patients from 15% to 35%. I know that doesn't seem like a lot, but when you're talking about 100,000 people in the United States alone per year who have this disease, that's a significant change in the number of people that you're able to help. In summary, over the past 100 years, there's been several milestones in radiation therapy. X-rays really picked up and they're used to treat cancer about 50 years ago. Linear accelerators 20 years ago, CT and MRI about 15 years ago. 3D planning came into effect about 5 years ago, but intensity modulation has only been going on for about 2 years, respiratory gating for less than a year, and the functional imaging is just now coming online. In conclusion, these recent technological advances, such as intensity modulation and gating, have significantly improved our ability to treat cancer with radiation. In many cases, patients who were previously considered untreatable now can be treated. And with the proper utilization of this technology over the next 10 years, survival rates will seriously increase and complications will decrease for many cancer patients. Thank you.
Okay, we have time for some questions for Chet. So,
what is the technique developed at the center?
The actual technology for delivering the treatment is developed by the manufacturer of the equipment. The actual delivery techniques are in part developed by myself, my research collaborators, both here and at Memorial Sloan Kettering.
Any other questions?
Yeah, what's Fred?
You do the imaging of the tumor in the patient with the techniques you described, and so forth. And you create the 3D model that you're going to use then to guide your programming for radiation with the accelerator. How do you benchmark the patient in 3 dimensions so that the imaging location of the tumor is what you actually irradiate when you do the irradiation?
One way of doing that is multiple imaging sessions of the same patient. For example, on the prostate, the CT image that we take is only one snapshot in time. The prostate's really moving all around over the course of treatment as the bladder fills and empties, the rectum fills and empties. One way is to take multiple 3-dimensional image sets and developing a timeline over time of where the internal anatomy is. As far as the localization, how do we correlate something inside of this CT volume to something on the linear accelerators within plus or minus a millimeter? The first step is an exact coordinate system. The CT scanner has a special tabletop on it that is indexed to match the tabletop in the treatment room. And both rooms have a laser system to define a coordinate system inside the room. And that's the first line of defense. The second line of defense is on the linear accelerator, we're able to image definitely bone. We can see bone no problem. In many soft tissues, we can see in X-ray images on the accelerator itself. And that's what allows us to fine-tune the position inside the patient.
So you compare those with the image that you took when you were imaging the patient.
Right. And part of the treatment planning process is we get images that the computer is generating images of what the films on the linear accelerator should look like in order for the patient to be properly positioned. So we check those on a weekly basis.
You envision the possibility in the future of integrating it more so that you image and treat in one operation?
In one operation. That is one of the things that I would like to do next year if I can come up with funding, is I would like to place inside the treatment room 2 fluoroscopic X-ray units that are orthogonal to each other so that we can obtain in the treatment position X-ray images of the anatomy and do online adjustments.
Any other questions? I have a question. I'd like to know about the Thompson Cancer Survival Center. How many different accelerators do you folks have? How many different X-ray machines? How many different gamma sources do you have? And then finally, what is the throughput of patients in the Thompson Cancer Survival Center?
Okay, we've got two high-energy linear accelerators like the ones that I showed here that are capable of doing intensity modulation. We've got one older single-energy, low-energy linear accelerator, so a total of three. We got the two different facilities. Each facility has a CT scanner, and the downtown facility has a conventional X-ray unit with fluoroscope on it. And the west facility, we're getting ready to put in one of these hybrid PET scanners. The treatment planning computers, we've got 5 Ultra 10s and 1 Ultra 2. The daily throughput for both facilities combined is 70 to 90 patients per day. It's about 900 new patients per year. And a patient during treatment comes in for about 15, 20 minutes per day, Monday through Friday, over a course of about 6 weeks.
Okay. Any other questions?
Is this a horrendously expensive thing, or it sounds like it may not be that much? It's hard to tell.
No, it's really not that much. It's not that. Given that this is medicine and everything is increased in the price that we have to pay for it by 2 orders of magnitude. The linear accelerator in Houston costs between $900,000 and $1.5 million. A CT scanner, $500,000 to $1.2 million. That in comparison to building a new hospital with surgical suites or a proton treatment facility that costs $50 million. Compared to those, it's relatively cheap. And the cost incurred by the patient or the patient's insurance is on average between $5,000 and $15,000 for the entire course of treatment, which also is fairly cheap compared to a surgical procedure that'll cost $25,000.
How much of this is considered conventional, and how much of it is considered experimental?
With medical devices, it's different than with pharmaceuticals. Everything that I showed you today is FDA approved, and FDA hates it when we say that it's approved. It's really called FDA 510K clearance, which means that the FDA has deemed that this machine, if used properly, won't kill people. We don't have to go through the same processes that say a pharmaceutical company has to go through to come up with a new biological. So all these are FDA approved. Are they conventional? I don't think so. If they were conventional, then the 7,000 or so radiation therapy facilities in the United States would all be using them. With 3D treatment planning, that portion is conventional now. I'd say about 90% of radiotherapy facilities have those now. Intensity modulation, at last count, there's about 35 places in the U.S. that do it. The modulated arcing, there's 3 places that do it, and respiratory gating, there's 3 places that are doing it. And this is, that have the technology and are actually using it to treat patients. There's lots of places that have the technology in it, and it's just not being utilized.
I don't recall that you mentioned treatment by using neutrons. Do y'all have the ability to do that, or do you have plans for doing that in the future?
We do not have the capability to do that, and this is where it really comes down to cost. If protons and neutrons, there are several cancers where there has been a proven clinical advantage, but a proton accelerator costs $50 million. neutrons, you got to have a reactor, and you're talking at least tens of millions to get a unit operational. And the number of patients that can be helped with those two modalities is very small compared to the cancer patient population in general. Plus, there's absolutely no reimbursement whatsoever for those technologies. So not only are they expensive, you don't get paid for doing it. So if somebody could come up with isocentrically mounted neutron proton generator that costs $1.5 million to $2.5 million, and I think it'd go into much wider spread use.
All right. Let's again express our appreciation to Chet for coming and giving us this excellent presentation.